Good morning, everyone, and welcome to the first session of the Carer Knowledge Exchange Research Incubator for 2023, Making Connections, Exploring Carer Health and Wellbeing. On behalf of Carers New South Wales and the Institute of Public Policy and Governance at the University of Technology, Sydney, I'm really pleased to formally introduce this year's Research Incubator event, which will be delivered over a series of online sessions over the next 3 days. As always, and to note, if you've joined these sessions before, this session is being recorded and it will be shared following the event on the Carer Knowledge Exchange digital platform. To start off our session today, it's my pleasure to introduce Savannah Finn, Youth Representative from the Metropolitan Local Aboriginal Land Council, who will welcome us to country. Thanks, Savannah.
Hi everyone and good morning. So my name is Savannah Finn. I'm a proud Wiradjuri woman from Dubbo, New South Wales, and I'm currently studying a Bachelor of Social Work at university. So I'm a representative of the Metropolitan Local Aboriginal Lands Council and had the cultural authority and endorsements under the Aboriginal Lands Right Act for the land we meet on today. I would like to pay my respects to all elders, past, present, and emerging, and extend that respect to you all here with me today. Traditional owners are not defined by hands or by a pen, but through the natural landscapes of the earth, that being Mother Earth. The nation's country covers the Hawkesbury to the north, the Nepean in the west, and the Georges River in the south. A welcome to country is more than just words. It is a spiritual process. So on behalf of the Metropolitan Local Aboriginal Lands Council members and elders, I would like to welcome you all to the land of the Gadigal people of the Eora Nation and extend that respect to all lands you are meeting from today. Welcome, 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 and thank you.
Thank you so much, Savannah. I think it's important for us to also recognise the importance of caring in Aboriginal and Torres Strait Islander communities and our responsibility to ensure that health and wellbeing of carers in all communities is a priority amongst researchers and practitioners. And we know the way that Aboriginal people experience caring is quite different to other carers across the community. So today's focus is on carer health and wellbeing. So why are we focusing on carer health and wellbeing? Well, we've had feedback from carers, of course, our networks, our advisory groups, which includes carers. And of course, the research shows us that carers have significantly poorer wellbeing than other Australians. Sources, including the Australian Bureau of Statistics and the Carers New South Wales National Carer Survey, also indicate that carers are also more likely to live with a disability or a long-term health condition, and to also experience high levels of psychological distress. So causes of this can include those everyday pressures of caring and the challenges of balancing that caring with other responsibilities. And those responsibilities might include paid employment, being part of the workforce, parenting, and also the increased costs of living, which everybody's experiencing at the moment, but those increased costs that are also associated with caring. So we also know that time and resources involved in caring often mean that carers do not have much time out to support their own emotional well-being or to manage their own health. And yet, health and well-being are absolutely critical, as we know, to ensuring that caring arrangements are sustainable and that they're healthy. When a carer's health falls apart, everybody's affected. The carer, the person that they care for, the broader family, their employers if they're employed, and their formal service systems. So it's really important that carers look after themselves and their health and wellbeing. Maintaining healthy, sustainable caring relationships is critical to the families, society, and the economy, and that's why we're focusing on this topic in our 2023 Incubator event today. So today we're going to start off with a 2-hour online panel focused on evidence-based initiatives to support carers' health and wellbeing, in which we will hear from some guest presenters, followed by a facilitated Q&A session. And immediately following that, we will have the Spotlight series of virtual poster presentations. Tomorrow's sessions will start at midday with the second instalment of the Spotlight series, followed by another online panel from 1 to 3 p.m, focusing on carers service navigation. And then there'll be 2 concurrent sessions to choose from. One, a workshop on social connectedness, and a symposium on understanding hidden and diverse groups of carers. Wrapping up the week on Thursday will be the 3rd Spotlight series from 12 midday, followed by a 2-hour online workshop from 2 to 4 p.m, focused on measuring carer wellbeing in research and practice. So there's lots of really exciting things that we're going to be covering over the next 3 days through those various sessions. And we're now going to move on to our guest presentations, which will introduce a series of projects led by researchers in New South Wales, Victoria and South Australia that aim to improve carers' health and wellbeing. So we're really honoured to have such a diverse group of speakers from a range of different locations across Australia. Reflecting the diversity of carers, our presenters will speak about initiatives to support older carers, carers of people living with dementia, and carers of people living with mental illness. So while only the panellists will be visible during the session, we welcome all of your comments and questions throughout the session via the chat and Q&A function on the bottom of your screen, and we will do our best to address those in the Q&A session following the 3 presentations today. So, our first presenter this morning. It gives me great pleasure to introduce Professor Lily Zhao, who has a teaching and research interest in the areas of carer support and education, chronic disease management, cross-cultural dementia care, and workforce development in aged care. She has an established track record in cross-cultural care of older people and people with dementia. Co-presenting with Lily is Eliza Chan, a dementia care advisor at the Australian Nursing Home Foundation. She has over 20 years of experience in Chinese-specific dementia care. So I'm going to hand over to Lily and Eliza to present to you today. Thanks.
Thank you, Ilana. Thank you for your kind introduction. I would like to begin by acknowledging the traditional owners of the Kaurna people, traditional custodians of the land on which I meet you today, and pay my respects to the elders past and present. And I hope my presentation will provide you with the latest research evidence on the effectiveness of the internet-based psychoeducation programs for cares of people with dementia, including the World Health Organization iSupport for Dementia program in Australia. I have invited Elisa Chan, who worked with me in the iSupport program, to the webinar to share her experience in the program. My PhD student, Ying Yu, has done an excellent systematic review and a meta-analysis on the effectiveness of the internet-based psychoeducation program for cares of people living with dementia. In this systematic review, we proposed that internet-based psychoeducation programs need to meet those 4 conditions. First, the programs are designed to improve care's capabilities in providing daily care activities for people with dementia and in coping with stress. And second, the programs are delivered in an online environment using the internet. Third, the programs have flexible and accessible online learning activities without physical or virtual location restrictions. And finally, the program may or may not have facilitators to work with carers. Our systematic review identified 19 intervention studies that met the inclusion criteria. Of those studies, 13 are randomized controlled trials, and another 6 are non-randomized controlled trials. Most of the studies were undertaken in North American countries or the European countries. We found internet-based psychoeducation program showed those characteristics. I just summarized on the slides. First, they were based on the theory. For example, the program designers always mention about they applied the stress and coping theories or other theories, for example, cognitive behavior therapy theory, self-African theory, problem-solving theory, or interactive learning theory. Second, the program enabled carers to access the website to gain the information they need without any restrictions. Third, the duration of the programs varied significantly, ranging from 3 weeks to 12 months. And fourth, the program used text-based content, videos, virtual reality, blogs, discussion boards, emails, and so on to enhance learning outcomes for carers. And fifth, the programs created opportunities for carers to interact with the peers and the program facilitators. In addition, the programs also assisted carers to make decisions through written recommendations on the website or through individualized meetings with the program facilitators. Through our meta-analysis, we found that internet-based psychoeducation program can significantly reduce carers' depressive symptoms. However, the effect size is very small, only 0.19. In our subgroup analysis, we found that when the program had facilitators to work with the carers, the effect size on reducing carers' depressive symptoms improved. On the contrary, programs without facilitators showed no significant effect on the reduction of the depressive symptoms. This is evidence that program facilitators are much needed in order to improve carers' mental health. We also found that internet-based psychoeducation programs can significantly reduce carers' stress. However, we found that internet-based psychoeducation programs showed no significant effect on improving carers' quality of life and self-efficacy, and on reducing carers' anxiety and burden. Future studies may need to combine internet-based psychoeducation programs with other intervention strategies to improve carers' quality of life. And based on research evidence, the World Health Organization has developed the iSupport for Dementia program, a comprehensive online or manual-based psychoeducation program for carers of people with dementia through international collaboration. I had the privilege of working with the WHO iSupport panel and contributed to the WHO iSupport program. The WHO also established an iSupport research network to enable researchers across the globe to share their knowledge and experience in the adaptation of the WHO iSupport program. So far, over 55 countries are in different stages to adapt to the iSupport program. In addition, WHO also established the Global Dementia Observatory Knowledge Exchange platform for members countries to share the iSupport program or other dementia care resources. The WHO iSupport program includes 5 learning modules and 23 units. The modules are described as the introduction to dementia, Be a Care, Caring for Me, Providing Everyday Care, and Dealing with Behavior Changes. Our research team in Australia commenced a journey to adapt the iSupport program in 2018. We formed the partnership with dementia care providers in the project. Our team members also included experts in dementia care research area. And based on our co-design process with the stakeholders, we made some changes to the WHO iSupport program, mainly in Module 1 and Module 5, to emphasize timely diagnosis of the dementia has many benefits, and the effective strategies and resources to prevent and manage changed behaviors in our Australian context. We also developed a new module entitled My Engagement in Consumer-Directed Care to meet the care's learning needs to manage aged care services for their loved ones in Australia. In 2020, we won MRFF Dementia Aging and Aged Care Mission grants to try the partnership in iSupport program in collaboration with Southern Adelaide Local Health Network, Campbell Health Services, Rest Haven SA, Bolton Clark. The trial includes 5 intervention components: managing transitions, managing dementia progression, psychoeducation for cares, cares support group, and cares feedback on aged care services. In other words, we have combined psychoeducation program with other intervention strategies identified by the stakeholders, and we are on the halfway to complete the trial. We also engaged our culturally and linguistically diverse communities in the cultural adaptation of the iSupport program. So far, we have produced the simplified Chinese version and the traditional Chinese version of iSupport program funded by the National Foundation for Australia-China Relations, Australian Government. I have had the privilege of leading team in those programs. We also produced a Vietnamese version and the Indonesia version of the iSupport program. Those programs are funded by the NHMRC eAsia grants, led by Associate Professor Chuang Liu. I had a wonderful opportunity to work with Chuang and his team in the adaptation of those versions. The Chinese iSupport program is designed as an aged care service research study across Australia and Greater China. In Australia, we received wonderful support from 3 Chinese ethno-specific aged care organizations. They are Australia Home Foundation, Chinese Australia Services Society, and the Chinese Welfare Services South Australia. The trial includes 5 intervention components: psychoeducation for cares and facilitate-led monthly online peer support group meetings, cares weekly interactions with chats and messages with the peers, and motivating cares in the program, while weekly short message sent by the facilitators and the individualized support for cares based on their needs. We just completed the trial recently. I'm very happy to report the findings from the trial in another webinar if it's needed. And the 3 facilitators in Australia's starting site have made great contributions to the Chinese iSupport program. And I get the permission from 2 facilitators to use the photos and the bios to honor their contributions. And I now invite Elisa to share her experience in working with cares in the Chinese iSupport program. Thank you, Elisa.
Thank you. Thank you for giving me the opportunity to share what I have observed and learned from the carers in this iSupport program. For me, wasn't the activity that the carers found most helpful in the iSupport program. The only thing that I can come up to my mind is the one that the monthly peer support Zoom meeting. They treasure this one very much, so this is maybe the only time they can share their frustration and share what they have tried at home to taking care of their loved ones. So I think this is really, for me, is really touching. And then throughout the 6 monthly meeting, and then only no one drop off, and only one missed one meeting because she need to take her mom to the doctor appointment. And also from their feedback in the meeting and their facial expression, I can know that they will enjoy listening to the others' experience. They take and then got some insight, and also they think about how to apply the tips or principle in their current situation, or preparing them for the futures. They're really interactive. So whenever there's someone. For me, the one, because that actually one of them, they got the COVID during the trial period, and because they have to isolate, but they can join in when they isolate in the room, and then she feel better, and then join us, and then this is so touching for me, and also from this peer group, the Zoom meeting. They feel that they are not alone anymore. Someone can listen to me. I can get some tips and some help. And for me, this is one. For me, is the last one when we have the feedback. One of the carers, she just told the other ones who also taking care of the mom, and then she just told. The other carer saying that maybe we can come up to have a coffee later on. And then, although I cannot help you, but I can cry together with you. So this is really touching for me, this is to my surprise, something like that. And also the activities, in the program is the content. Some of the content is really user-friendly, they are really the up to the point, and this is one of the carers who is really handling her. She's always attending a lot of the carers education hosted by Dementia Australia. But at the end of the trial period, and that she said that she herself think that she was very resourceful. But after this program, she just think that she feel a little bit guilty, because she said that if I know those information or the skill before, and my dad will have a better life, in his last 2 years. Why she said so? Because of her father got dementia, and her mother was a primary carer for his daddy. But later on, after her father died, her mom onset the dementia, and she became the primary carer. And then she felt that, now it is a different story, because I am the primary carer. And then if I know how to take care of my mom now. So this is really touching, for me. This is so surprising. She used to be a teacher, and she used to be really click every information from online, So I think this is really helpful, the content and also the peer support monthly meeting. And also for the second point is about the challenges that the carers encounter during the program. Is most of them, the feedback is they can't really quiet down themselves and then free their mind, to read the information or do the relaxation breathing exercise. For them, this is hard, and then they just feedback that during the first month or 2 months, and then they said that when they sit down and try to do the relaxation breathing exercise, after 1, 2, 3, and then she's in her mind that she think about I have to do something, and my mom is something, my dad is something, so they can't quiet down. but we encourage them to try again and again. And then by the end, they said that, wow, it's really helpful. At least I can take some deep breathing whenever I got irritated or I feel angry, and then they can just get to the room and then or to the toilet and then breathing. This is what they share in the meeting. I think it's so wonderful. And also another challenge is they in the second module they recommend to find someone to help. And then they can share that it is hard for them to find even their siblings to help because they don't know how, you know. But in this module, they have some tips telling them how to get help from your family or friends. And then this is really good for them. At least they know in their mind, and then they will try. And then we encourage them to try. You know, some of the carers in the meeting, they have their sisters living with them. They share the caring role, and then they can encourage those living with their mom, and their brothers maybe living far away or in other places. But they really feel encouraged. And be encouraged by the others, and also they feel, yeah, someone listened to me, and then someone know my difficulties. And also another challenge for the carers it is hard for them to re-engage. I mean, or to enjoy some activities, the leisure activities that they used to attending. Because of the caring role, you know, they're always thinking about is how to make my dad or mom or my husband feel better, or how to ask for other help, apply for other help, or whisper or day center for my mom, so on. And then also they have their own children, their own family. They are so occupied, so it is hard for them to spare sometimes to get to join some painting class or music, or go to have a coffee, or sit down to read a book quietly by themselves. So this is the challenge that they know, and then we keep on encouraging them. And then how I help them to overcome those challenges for them. And then what I do is during the meeting, I always encourage those have the experience to ask for help from their families, or have the experience to have a regular coffee time with their one or two of their good friends, you know, share the experience and encourage those don't know how to ask for help, you know, or how to get some leisure activity for themselves. So this is really good interaction in the meeting. And also in the weekly, we have the WeChat group, and then I send out the encouraging message, and then some hints or send some videos, how good the exercise is, what is the stress relief thing, simple exercise for them, and also they encourage them to participate, to try it out, and then talk about it in the next Zoom meeting. And also during the meeting, when I find someone is so frustrated, or they got sick, or their partner is not so supportive, and then I will call them individually during the week, and after the meeting, and then see how's going, and just say hi or something, and then let them talk. Then they can just keep talking to me, and then somehow I give some option and suggest to them, maybe you can try this, maybe you can do something like that, and see how's going, and then tell me next time in the meeting. So they feel a little bit, you know, can engage in this type of the mutual encouragement with amongst the carers. And also I can keep what the facilitator can do. And sometimes in the chat, in the WhatsApp group, they ask for where can I get some kind of this type of service or this type of service. Then I will suggest to them, and then most of the time I just call them. Oh, is this time to talk? And then I call them and then tell them what to do, or where to get some information. And I think this is mainly what I can help as a facilitator for the group members. I think this is really rewarding for myself. I can see that they are really good together, and then they treasure their moments, only 40 to 1 hours per month. And then for the 6 months, they can build up the friendship. Only some of them, but only 2 or 3 of them, they can keep connecting together. But the others, they are busy and then they're not connecting. And also, we can refer 2 of them to join our dementia carer support group in Sydney. So this is really, for me, that's what I really want to do. I really want to help. Thank you.
Thank you, Elisa. Thank you for sharing your experience. And we are happy to, Elisa has another commitment. She has to leave. And I'm very happy to answer any questions later. Thanks. Hand over to you, Ilana.
Okay. Thank you. See you all.
Thank you.
So Lily, was there anything else that you wanted to add from the presentation?
No, and perhaps, I'm happy to answer any questions from our audience later. Yeah. Thanks.
Okay, fantastic. Because I think both you and Elisa have shown, I think, something that, we often talk about, but that real value of peer support and that positive impact that it has on carers' health and wellbeing. And I think what Elisa was talking about in terms of some of those challenges that carers see, that through the iSupport program and that peer support group meeting monthly, that it's really giving that permission to the carers to be able to do those things, to address some of those challenges, to be able to go and have, a coffee with their friends, but really to take that time out to for some time for themselves, which I think is so important. So thank you both so much for that. That was fantastic. And we're now going to move on to our second speaker this morning, Professor Keith Hill, who's coming to us from sunny Darwin on his holidays, which is fantastic. So gone above and beyond today, Keith. Keith is the Director of Rehabilitation, Ageing and Independent Living Research Centre at Monash University, which is co-hosting one of our concurrent sessions tomorrow afternoon. Professor Hill is a physiotherapist and a senior researcher with experience across a broad range of areas related to healthy ageing, including projects that focus on the health and wellbeing of carers. So I'm going to hand over to Keith now to speak to us about his work with older carers. Thanks, Keith.
I want to thank Alana and also Sarah Jane Judd Lamb and the team there for this session, the 3 days coming up, and also for the Melbourne satellite event that our team at Monash are running tomorrow. I also want to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to lands, waters and communities. And I pay my respects to Aboriginal and Torres Strait Islander cultures and to elders past, present and emerging. And you can see here a few of the images of the countries that I've been involved in to date. And the Bininj and the Mungai people of Kakadu and the Larrakia people of Darwin. So I'm going to focus on this a little bit of a journey that I've been on, and this started in 2018 or a little bit before that when I was at Curtin University. And that was some work led by Chris Toy, who was a nurse at Curtin University, and she applied for what was called a FAPES grant, which was a small grant to try and bring together researchers from Brazil and and Australian universities, to develop new programs of research collaboratively internationally. And so with a small team, Sue's later a nurse as well, myself and Alyssa Burton, a sports scientist, we linked up with Alessandro Jacinto, who was a geriatrician in Brazil, and established a small program of work. The funding was very small, it's seed funding there, we were able to supplement it with a little bit of extra funding from Sir Charles Gardner and Osborne Park research group. But the 3 bits of work that this initial focus was we did a systematic review, and this was trying to look at what might be the best health literacy tool for older people and their carers. Our particular focus was on carers, and in particular older carers of older people, but to be pretty broad, because we knew there wasn't much work in this space, we looked at older people generally. And the results of that did identify that there wasn't a lot out there. We looked at what was being used for older people generally, and the health literacy questionnaire, the HLQ, was the best tool that was identified in that. We then did a bit of work, particularly focusing on carers of older people in Australia and Brazil, and looked at the reliability of that tool for carers of older people. And then we undertook a small test program to support carers of older people who were being discharged from hospital, who had a lower health literacy. It was only a pilot program, gave us a little bit of extra information, but just to let you know that little series of events. But the main aim of it, as I said, was to try, after that little bit of work, to develop a new collaborative project that we would submit for funding together. And so that was where our journey as a team started. You can see now that our team has grown substantially, and this is still an international team with colleagues in Brazil and in Australia. It's a very interdisciplinary team: physios, nurses, geriatricians, exercise scientists, clinical psychologists, occupational therapists, social work, some input from Carers Victoria and from the Mornington Shire Council and our project team. This project was funded by the National Centre for Healthy Ageing from 2020 to 2022. And I'll be focusing on a couple of elements of that piece of work that brings us to the new project that we are now going to be embarking upon. So just in terms of that project that was funded by the National Centre for Healthy Ageing, as I said, the focus was on older carers of older people. We define older carers as people who are aged over 50 years of age, and the older people that they're providing care for as being over 65 years of age. What does the research evidence say in this area? Firstly, why do we target carers generally? You would have got a sense from Lily and Eliza's presentation, but also more generally, there's a high level of unmet needs for carers generally. A lot of difficulties navigating what is a very complex system, and there's a need for quite a substantial change, I would argue, in this space. So it's thinking about carers generally. Why should we target older carers, and in our case, older carers of older people? But older carers often have moderate health problems of their own. They often have difficulties juggling their care commitments and having time to manage their own health and well-being. They're often a spouse carer, and that brings up some other issues, often providing high levels of care and often providing care to a person who is receiving care who has complex health needs. And one subgroup in that case are people with dementia, who we heard about in that previous presentation. So when we started in this space, we did a quick search of the literature, just looking for anything focusing specifically on older carers. And there was very little research in that, from that search. 7 papers that I identified when I did a quick and dirty search at the start of this process. Most research out there does evaluate carers across all ages. And, you know, there's a lot of very good value in doing that sort of research. And there's also a large subgroup of the research evidence out there that focuses on people who are receiving care, the carers of people who have specific health conditions, such as carers of people with stroke or carers of people with dementia. And again, that's highly valuable, because even though there's some generic issues that affect all carers of whatever age and whatever the conditions of the people that they're providing care for, there are some specific needs for particular subgroups with respect to the condition of the person receiving care. So all of that's highly valuable, but none of it really helps in really focusing on that older care of older persons work. So with our bit of preliminary literature review, we did look for what might be beneficial from the research evidence to help the health and wellbeing of older carers. As I said, there's very little focusing specifically on this group, so we looked at any samples that did include older people looking after older carers. So, but they were usually across all ages, the research evidence that was there. The things that did show up as being likely to be able to help the health and wellbeing of older carers: physical activity and exercise, improving knowledge and use of technology to support health and training, and also that's really focusing on ability to use electronic media to obtain health information and to engage in health activities. And it's particularly beneficial in rural and regional areas, but not specifically. It can also be highly valuable in metro areas. There's also evidence around health advice and information being provided, and that can be for the carer themselves, but also for helping them to understand the needs and the health, what to do from a health point of view for the person they're providing care for. And one study we did looked at working in a co-design approach in terms of false prevention for the care recipient, which actually had some health benefits for the carer. There's also periods where there's increased levels of care needs, and post-hospitalisation is one of those. And so interventions that target the older person coming home from hospital in that first month or so, and support for the carer at that time, can be valuable. And also some work looking at improving carer health literacy. So then the next piece of work that I'm coming to from which was funded through the National Centre of Healthy Ageing, was this collaborative work looking at combining some information from Brazil and from Australia. In Brazil, Alessandro Jacinto, the geriatrician I mentioned, was involved in what we found was the only evidence we could see in the literature about a carers clinic for older people, older carers. It had a very medical and psychological support focus, but it's the only one in the world that we've been able to find from our searching. So we've brought them together, and with that we undertook a range of studies, 3 different studies in Australia. We looked at surveying older carers, we looked at interviewing staff and carers of older people receiving care at geriatric clinics in Victoria and Western Australia. And the third phase was to look at co-designing what we hope would be a novel multidisciplinary carer clinic to address the needs of older carers, of older people. So at the end of all of that, we had 189 surveys and 14 interviews of older care partners. We had 21 interviews with health professionals in Australia and 4 in Brazil, and we did a co-design component with 15 panellists in Australia. So the survey component, I'll just go through a few of the results from that, but the aim of this work was to identify and evaluate the type and adequacy of existing information and support sources used by older carers of older people in Australia to manage their physical and mental health, wellbeing and caring needs. This was an online survey. We had 189 responses across 4 states. The carers were on average 68 years of age, 83% were female, 73% lived with the care recipients. The care recipients on average were 82 years of age and 44% were female. And 56% were in that spouse partner relationship with the care recipient. The main health conditions that the carer was providing care for from the care partner point of view: dementia 41%, arthritis 36% and 34% heart problems. And this was a reasonably experienced group of older carers of older people, with 60% having more than 4 years duration of care giving. We asked about interactions with medical and health services, particularly the general practitioner, 83% said that the general practitioner was aware of their carer role, and so 17% the GP wasn't even aware that they were a carer. And the 46% said that the GP actually provided assistance and advice from the perspective of their carer role. So a large proportion were not really getting much in the way of their carer needs addressed through their general practice interaction. The main types of assistance that they received from the GP were referral to support services, referral to another health professional for their own health, written information and suggested health checkups. We also asked about the care recipients and how many of them were attending specialist clinics, which we thought might be another avenue where, because of the focus on older people and their need to remain at home, that there might be strong focus on the carer as well. 57% of the sample that we interviewed, or that we surveyed, had attended specialist clinics. These included geriatric clinics, cardiac clinics, falls and balance clinics, and so on. But only 19% of these carers who attended the clinic for optimising the care of the care recipient actually received any advice themselves about their carer role. And so what we thought might be a good avenue for extending and supporting carers doesn't seem to be happening all that often in Australia at present. We asked carers about the importance they placed on ensuring the health and well-being of the person they care for. And on a scale of 0 to 10, 97% really put a very strong emphasis on the care of the care recipient and the health and well-being. So that was their primary focus. When we asked them about how much focus they put on their own health and well-being, it was substantially less. So 63% highly rated, above or equal to 8 out of 10 on this scale, that they put a lot of emphasis on their own health and well-being. When we look at their own rating of their quality of life, around half of carers indicated they had a very good or a good quality of life, and so that's excellent. But nearly a half also indicated average poor or very poor quality of life. And so there's a lot of room there for activities that might help to improve a person's health, well-being, quality of life, and also even for those who are rating themselves as good or very good from a health promotion point of view, what can be done to try and keep them at that level while they're sustaining the caring role. We also asked about barriers to ensuring their own health and well-being, and not enough time. Competing demands were clearly big ones. My own health problems came up, and so again, if we can work to help to optimise the carer's own health problems, that's likely to be beneficial in multiple ways. We also asked what organisations they accessed information from, and carers organisations were the big one, 74%, and Dementia Australia was another strong agency for seeking of information, obviously for those who are caring for someone with dementia. So that was a snapshot of our work that was done looking at the survey nationally in Australia. We then followed that up with interviews with health professionals and care partners of people who were attending specialist geriatric clinics in Australia. So we had 21 health professionals, 7 different disciplines who were working in the various specialist geriatric clinics in Victoria and Western Australia. And we also interviewed 14 care partners who attended these specialist geriatric clinics for the assessment and interventions for the person they were providing care for. Just very briefly, the findings of this work showed that clearly the focus of assessments and interventions are on the care recipient, so the carer is very often not the focus. And in fact, we did hear through some of those interviews that, you know, as a clinician, I'm only funded for the person who is my patient, as in the care recipient. I'm not funded in this job, in this assessment, to assess the carer as well. And that's a potential problem because clearly Success of the dyad from a sustainability point of view relies on the health and wellbeing of the carer and the care recipient. There were instances though where the health and wellbeing of carer was evaluated, and so it's something that is occasionally happening, but it's not widespread. Carers also often reported feeling neither recognised nor valued for the essential role they fulfilled, and that in itself is also another problem and a challenge that those working in this area need to try to turn around. So there's a lot more in this, and our project team led by Aslan Lawler, Susan Slatcher and Moira Watson are writing this up currently, and we'll be presenting in great detail shortly. But the third arm of this was to try and bring together this research work and to have a co-design panel that included 15 people. We had 3 older care partners, some health service administrators, health professionals who provided care for older care recipients, consumers, stakeholder organisations, and a couple of external researchers who looked at the various bits of data from our work and from other research and their own lived experiences. And at the end of this, we wanted to come up with a model for what might be an optimal service to support the health and wellbeing of older care partners, of older people. This is a very busy slide. There were a lot of different messages that came out of this work, but these are some of the key principles for such a new service to be built. It needs to avoid silos, avoid duplicate, but also avoid duplication of existing services. There's a lot out there, and we don't want to duplicate that. But there's a lot of gaps. Facilitate and the navigation and linkages. Clearly, that's an issue. There needs to be an assessment of the carer needs and priorities, which there's a lot of things out there, but they're not specific to a person. And to get that specificity, you need to look at having an assessment, timely access to this service across the carer role and trajectory, including pre-caring and post-caring role, personalised management, single point of coordination for the carer, relevant, provide some training for health professionals and students and next workforce, and a range of other elements, including flexible mode of delivery, and focus on physical, mental health and wellbeing, but also financial, health literacy and sexual health were also raised. So it's a fairly big ask, a fairly complex service that came out of all of that work. We then put up what we consider to be a gold standard application, like if we really wanted to do this well, what would we need? And we put this to NH and MRC, but were unfortunately unsuccessful. This was for a $2.5 million grant over 5 years across 2 states, substantial staffing, flexible in-person telehealth options, able to deliver quite a bit of the interventions directly without having to refer off, but also having a referral opportunity, and also conducting strong research along the way with qualitative outcomes, but also an economic evaluation to try to understand the cost if this was to be able to be scaled up. And so unfortunately we weren't successful there, but we were successful in obtaining a smaller amount of funding from the National Centre for Healthy Ageing, 3-year project, $500,000. So we've been able to scale down at what we thought was the gold standard model to what hopefully will be a good serviceable model, and we're hoping to start that work in July. This is just a very busy slide, but it's a bit of a model of how people we hope will move in and out. It's very much focused on carer needs and their prioritising of their needs and what we can provide. And so it'll be different for every carer who comes into our service. So it will be a flexible model of a one-stop shop, hopefully, to meet care partner supports and their health needs, provide multiple avenues of support with assessments and care partner prioritised interventions, generic information and condition-specific information, advice and support. So in summary, older carers of older people provide a highly valuable role that is often poorly recognised, and it can impact on their own health and wellbeing. There is a small amount of research out there that does show that we can have some positive physical and mental health and wellbeing outcomes by putting in place specific interventions. But it does seem as though the current system has quite a lot of gaps and challenges from a navigation point of view. And so hopefully what we're going to be doing is answering the question at the bottom of this slide: can a new co-design service meet this need? And so I'll come back and talk to you in 4 years' time and let you know the answer to that. Thank you.
Thanks so much, Keith. I think there's so much in all of that, particularly obviously starting with the international nature and that linkage with, you know, the work in Brazil. And I think importantly, I mean, all of the things that you've identified around some things that will, you know, assist with carer health and wellbeing, some of those gaps in those linkages with health professionals that are often in touch with the person being cared for, not necessarily focusing on the carer, and some of those other barriers to carer health and wellbeing. So I think that's, you know, bringing that all together, and in that model that you've developed, I think is, you know, really important. And I think, you know, looking forward to seeing where that goes and the results of what might happen there in that sort of site in operation. So I'm sure there'll be many questions around that later on this morning, but that was a fantastic overview. So thank you so much. So our third section of speakers this morning is Dr. Sally Fitzpatrick. Sally's a program manager at Everymind. She's also a clinical psychologist and researcher who is passionate about the prevention of mental ill health and suicide, as well as the promotion of wellbeing for all Australians. Sally's program and research work is focused on understanding the factors that contribute to mental health and wellbeing and the translation of this knowledge into evidence-based programs for families, carers and communities, something that the Carer Knowledge Exchange is very focused on. So this is great. Presenting with Sally today is Charmaine, who's a carer, who's also contributed to our Minds Together program and has recorded a video about her experiences of being a carer. And she's been a carer who's been bereaved by suicide by her daughter, and also a carer to her son who's previously attempted suicide. So really important to have that carer voice within this work. And I'll hand over to Sally and Charmaine for our presentation. Thank you so much.
Thanks, Elena. I'm just going to share my screen now. I'd like to start by acknowledging the traditional owners of the country in which I'm on today, the Awabakal people, and pay my respects to elders past and present. And I'd also like to acknowledge those attending today's seminar with a lived or living experience of mental health concerns or suicidal distress, including family and friends who provide care and support for someone experiencing distress. As Elena said, I'm a program manager at Everymind, and today I'm joined by Charmaine, who's one of our wonderful lived experience representatives. And I'm going to talk to you a little bit about our family and friends program we have at Everymind, and Charmaine will talk about her involvement in one of these programs. For those of you who don't know about Everymind, we're a leading institute dedicated to the prevention of mental ill health and suicide. We're based in Newcastle, a couple of hours north of Sydney, but we work nationally across Australia, and we've been delivering best practice mental health and suicide prevention programs for more than 30 years. And one of our priority program areas at the moment is focused on family and caregivers and how we support the people in their lives, but also how we support them. And in doing this, we developed the Minds Together program, which is a suite of online and face-to-face resources and learning modules specifically for family and friends supporting someone experiencing mental health concerns or suicidal distress. So why are we focused on this particular group of family and friends? Because in this country, we continue to have a significant challenge with the prevalence of mental health concerns, mental illness and suicide. We know from the research that more than 2 in 5 Australians experience a mental health disorder in their lifetime. We know that anxiety, depression and substance use are most common. We know that more than 3,000 Australians die by suicide every year. 65,000 Australians attempt suicide every year. And we know that more than half of those experiencing mental health concerns don't actually seek formal support, which means that most of the practical and psychological support for those in distress actually comes from the family and friends around them. So who are these family and friends? Well, I'm talking to the converted today, but for the sake of clarity, the family and friends that I'm referring to are those who provide unpaid care and support to someone experiencing mental health concerns or suicidal distress. And we know this often occurs in the context of other health issues, and we've already heard around disability, dementia, or could be alcohol and other drugs. But our focus means that mental health concerns are occurring for the person being supported. In working in this area, we know that most family and friends don't identify as a carer or actually be in that caring role. They're just mums, dads, parents, children, relative, friends, colleagues, just trying to support the person in their life. And so they often come into the support role without planning to do so, which means they don't often understand what's happening for the person they support, and they don't know what they can do to help them. So we need to invest in supporting those who are actually doing the supporting. It's really important because one of the challenges in working with this group of family and friends is that we know that whilst they're supporting the mental health of someone in their life, their own wellbeing and mental health can also be affected. And this can include increased financial stress, higher levels of psychosocial distress than is found in the general community, and feelings of social isolation. So we end up in a situation where we have a person experiencing a level of distress, and the person or the people around them and supporting them also are experiencing distress, which is why we believe it's so important to focus on this particular group of family and friends. So in developing our Minds Together suite of programs, we took a fairly standard approach to the development of the programs. We started by listening to family and friends. We conducted national consultations for each of our programs through surveys and interviews. We formed steering groups for our projects that included experts, but we also made sure that we included people with lived and living experience in these groups to ensure that we developed content that was specifically tailored for them in specific contexts. We built our knowledge by conducting reviews of the literature and looking for the best evidence of how to develop online programs for family and friends. And particularly, we took our programs and developed them within specific contexts. Whilst we know that there's a level of similarity experienced by most family and friends, different contexts require different information. So, for example, supporting someone who's attempted suicide is going to look different and need a different response to supporting a first responder experiencing depression. And finally, we also include a connection to other family and friends through linking them to an online social forum. So the goal of the program really is to build the capacity of these family and friends in their support role. We want to be able to increase their mental health literacy and build skills through low intensity cognitive behavioural therapy strategies, as well as build wellbeing and coping skills. So the program uses a mixed media format. We have short videos and podcasts, case studies, activities, worksheets, and reflective questions. And to date, we've developed 3 of these online programs: family and friends supporting someone with their mental health with a focus on anxiety and depression, family and friends supporting the mental health of paramedics, and family and friends supporting someone who's attempted suicide. And I'm going to go through where we are in the development and the research of each of these programs in a second, but I'd like to really at the moment share with you a short video from our Minds Together family and friends supporting someone who's attempted suicide, and show this as an example of the sort of content that's within the program. In this video, you'll see Connor and his mum Charmaine talking about their experiences, and then we'll come back and Charmaine can talk about what it was like for her to be involved in this project.
My name is Charmaine. I provide care for my son Conrad, and it's been 11 years since his first attempt, There hasn't been any other attempts, and yeah, it's been a very insightful journey.
It started from a very young age because my older sister, she was, very much in that mindset. Something goes wrong, it's like everything goes wrong. But yeah.
And who's the support person for you?
My mum.
One of the things that we as parents have to really take care of is that we actually just on the journey with our children. They're not our property. They're not an extension of who we are. It was good to have that sobering type of thing, to understand that Conrad is still Conrad and that he still has choice. He still has freedom. And that was, I think, the hardest thing for me, is to take on a different role.
Charmaine, what I'd like to do is invite you to turn your camera and your audio on. And if you can just briefly tell us why it was important for you to be involved in this program.
Okay. Firstly, being able to be part of something that's bigger than yourself takes you through the road of compassion, because with Every Mind and the whole program, you sort of start to find out that there's more to life, and that your lived experience can bring insights, can change and can educate. So on my journey, people have asked me, what has made a change? And losing a child sort of unlocks compassion, where you start to realize that everything connects. Everybody is connected. And with my journey with Conrad, and even watching the video now again, brought tears, because true intimacy is how truthful you can be to yourself, how you can face who you are in difficult moments and still hold to the positive. And me and Conrad, our whole journey has evolved into working together, because there's times when I'm weak and he becomes my carer, and other times the roles reverse. The universe has also got a wicked sense of happiness. Conrad became a dad on the 29th of April last year, the 22nd, and that was Shani's birthday, my daughter that passed. And what was a very heart-sore and tearful day has now turned into another joyful day with a life that's there. And being part of this lived experience program has shown me how many people care on every level. And being able to surrender that and to know that there's a validity in what I've gone through, because it wasn't easy. But in a way, you learn to hold life loosely. You share when you can, because in the beginning, all you want to do is share. And you actually realize that there's a place for everything, just like a season. And when your experience is used in the correct way, it's not a hit and run. It's something that has a purpose and has a grounding. And I would encourage anybody, if you're able to talk or share or whatever, become part of a research program and live with them, show them, give them insight, because everybody's experience is different and the texture is different. But when we band together and we become a compassionate unit, it means that we're caring not just for this moment, but for the future. Because suicide has been with us since the beginning of time, and it'll always be there. But how we deal with what is happening does make a magnificent difference. Thank you, Sally.
Charmaine, that was absolutely beautiful. Thank you. And we absolutely cannot do, nor should we do these programs without family and friends who have this lived experience guiding us all the way. So what I'm going to do now is go back to the slides, and I want to tell you about where we are with each of these programs.
Thanks, Sally.
So what I want to do is give you a brief overview of where each of our 3 Minds Together programs are in their development. And I'm going to start with our family and friends supporting someone with their mental health. So we started this study with a consultation study, as I outlined earlier, and we found that the majority of family and friends said that they supported someone with a formal diagnosis of mental illness. Mostly that was comorbid anxiety and depression. Most were female carers aged in their 40s and 50s, and they were supporting a male. We also found that nearly a quarter of these carers were experiencing very high levels of psychological distress, which is much higher than the general population. But despite the impacts of the role, these family and friends appeared to be well invested in the wellbeing of the person they support, and they had a real desire to increase their understanding and ability to be able to support the person in their life. We've recently conducted a full randomised control trial to check the efficacy of the program. We had 127 participants. Again, most were female family and friends supporting a spouse or a partner with comorbid depressive and anxiety symptoms. And participants who completed the program reported improved quality of life scores overall. And this was underpinned by 2 key factors. The first was increased coping self-efficacy, and this refers to a self-belief in our ability to cope in the face of difficulties, such as can occur in the caring role. And we know from the research that if we can increase coping self-efficacy, this is strongly correlated to changes in behaviour for people whose self-efficacy does increase. So it's a really crucial factor to be able to improve that for carers. We also saw in this RCT a decreased perceived carer strain in those that completed the program. Feedback from participants in the trial was great. They commented positively about the content, the relevance and the structure, and they reflected on how the program reinforced the importance of their caring role and strengthened their motivation for self-care. We then moved on and contextualised this program to first responders with a focus on paramedics. We know from the literature that there's a really high prevalence of mental ill health in ambulance personnel generally, and they have a higher rate of suicide when compared to other occupational groups, and even when compared to first responder groups. They also have a low level of seeking help from formal organisations. So again, we consulted with paramedics and we consulted with their family and friends. We found that half the paramedics that we consulted with, or half the family and friends we consulted with, were supporting someone, again, with a formal diagnosis of mental illness, predominantly anxiety, depression and PTSD. We found that family and friends were saying that suicidal behaviour was high in the paramedics they supported, and that stress was coming from trauma they experienced at work, shift work, stigma in the workplace about help seeking, and a perception of limited support coming from their workplace. We also found that nearly a quarter of the family and friends themselves reported experiencing high levels of psychological distress and strain. So we're currently testing this program in a randomised control trial, comparing the intervention to a wait list. Again, most participants so far, and we're only early on in the trial so far, most are female, supporting a male spouse with a formal diagnosis of mental illness, and there is, again, a high level of suicidal behaviour. I have to say, though, in saying this, we need to remember that to be included in the trial, our family and friends need to perceive there are mental health concerns or suicidal behaviour in the person they're supporting. So these numbers are going to look a little bit higher than I think we would expect to see in a community sample. But I also think they're representative, as per our consultation, from the level of distress that's occurring within this group. And finally, we have our family and friends supporting someone who's attempted suicide program. We're currently undertaking a pilot study of this program, which aims to evaluate the feasibility and acceptability of the program. To this point, we have 60 participants in the study. Again, most family and friends are female. They're in their 40s, and they're mainly supporting men in their lives, and these are parents, spouses, or children. Feedback so far has been really positive, with a real focus on how helpful the videos are. And I think you could see from the video with Charmaine and Conrad how powerful it is to actually hear from those with the lived experience of being bereaved by suicide, but also supporting someone with suicide, how that can be really helpful to other family and friends going through a similar experience. So let me really briefly touch on the challenges and successes we've experienced in developing these programs. Each of our programs has shown that they're acceptable to carers and that they're safe to use, and that's absolutely crucial when we're talking about mental health and suicide. Participants have told us that the lived experience videos and stories are relatable and they find the content extremely valuable. They really like a mix in the content delivery, so videos, written content, interactive activities, and the link to the social forum. Our research has contributed to a current gap in the evidence for interventions targeting community dwelling carers of people experiencing mental ill health or suicidal distress. There's very little out there targeting this particular group of family and friends at the moment. And most importantly, our programs are demonstrating improved quality of life for those who are involved. We're seeing an increase in coping self-efficacy and a reduction in caregiver strain. So overall, they're showing benefits to the family and friends who participate in the programs. Of course, where there's any online program, there's going to be some challenges. And although online programs have great elements of interactivity and presentation of different media and voices, the content's standardised, and that's what happens when you develop an online program, which means it's hard to meet the needs of every single person using the program, and that's a challenge we need to face. Participants don't always look at every page in the program, so we have a challenge in how to get them to engage with the content which is most meaningful and beneficial to them. We also know that family and friends are so busy, so actually getting time to start and finish the program can be really difficult for them. And recruitment is a significant challenge. As I said earlier, family and friends don't identify as being caregivers, so actually reaching them to do this sort of program is really tough. Where to for here, or where to next for here for us? We're going to continue to how to explore online interventions and how we use them for family and friends. We're going to ensure that we continue to include lived experience perspectives in our content and be guided by the voice of lived experience. We want to broaden the peer-to-peer support of Minds Together. We currently link the program to a social forum, but we'd like to build in some peer-to-peer support. And finally, we want to be able to develop content which meets the specific needs of family and friends where and how they need it. So if you're interested in our programs, we currently have 2 available still in the trial program. So please go to the website and access them. And finally, I'd like to finish by acknowledging our funders, and particularly those family and friends who have worked with us through the development of these programs. Thank you.
Sally and Charmaine, thank you so much for sharing that. I think, Sally, at the beginning, I think you said, you know, this is focusing on support for those doing the supporting, you know, and I think that's been very important and a really key message. But I think Charmaine's really shown so well the absolute value of the lived experience of caring and sharing that experience with all of us, but also obviously as part of the program through the video that you've done, and really sharing that. And as you said, the ability to share and when it's right to share and the importance of sharing, I think really has come through in what you've done. But all of those, the Mind Together programs really, some really, really fantastic key messages there. Also identifying the challenges, a lot of those challenges that we experience in different ways in all of our programs, that recruitment of carers not identifying as carers, but how important it is for that peer support and that capacity to be able to identify themselves as carers and then open themselves up to that sort of sharing of information and open to that support, which I think is really important. Of all the cohorts of things that you were talking about of different carer groups there and family and friend carers. So thank you both very much for sharing.
It's been a pleasure.
Thank you.
Thank
so
you.
For everybody else joining us all back now, we've now got sort of a Q&A session with our panelists. So I'm happy for people to put any questions in the chat that we can get to. But we've got some questions now. So if Keith is there as well. I've got some just a general question for all of the panel members to answer. So just to, I suppose, just unpack a little bit more around the work that you're doing and your role within research. Our first question just focusing on how did you first get into research about carers' health and wellbeing? So I might start off with Sally, because she's at the top of my screen. Sally.
It's a great question. I've spent the past 30 years working with families and friends, working with people experiencing mental health concerns, and I love this work. I've been a clinical psychologist, a researcher, and a leader of projects. But a couple of things have stood out to me. As I said in my presentation, more than half of all Australians don't seek treatment around their mental health. They just don't come to see a psychologist like me, which means they're not getting help, and most of the support they're getting are from those people around them. So the second thing I noticed is that we don't actually help those doing the supporting. Most family and friends come into this role by virtue of being in a relationship with someone they care about. They're often unprepared for what to do or how to do it. And I think we have a real need to be able to support those doing the supporting if we want to see a reduction in mental health outcomes for those in distress, but also making sure that we're not seeing an increase in mental health or mental ill health outcomes for our caregivers.
Yeah, fantastic. Thanks, Sally. Lily, how did you get
Thank
into
you.
this?
Thank you. That's a great question. And I remember my first project after my PhD was a caregiver project for those from the dementia care field. And I won the first setting grants from Flinders University. And I developed a passion in that area based on my personal and professional experience in that area personally, and I observed how my mother looked after my grandma when she was an old person as well. So and how she experienced stress and burnout, and how the family had to step in and support her as well. And professionally, I worked in a hospital and back to my home country in China. And also when I migrated to Australia, and I worked in aged care through my PhD studying period as the casual registered nurse. And also work with the research group at Flinders in aged care. And through all the professional experience, I also observed the family cares of people with dementia. They experienced a very similar situation my mother experienced, and I experienced when I supported my mother. And so that's the experience after the setting grants. And I was encouraged to apply for the DCRC and the RCT trial, and work with large group of the cares across different states as well. And then gradually formed a research team and recruited PhD students. And we continue working this area, because we believe the family carers, they need support, and the community and the society, they need our research evidence to improve the policy, to inform the policy and the practice. Thanks.
Thanks, Lily. I think that's things once you get sort of bitten by the carer bug, if you like, you know, you do develop that absolute passion for it, and I think you can see that in all of the work that you're doing. So Keith, do you want to share with us how you first got into research about carers' health and wellbeing?
Yes, it's interesting looking back on that. My PhD came in 1998 and was in the area of falls prevention for older people. I also had a pretty strong focus on exercise as a physiotherapist, and so those were really my passions in terms of where I was going to be going with my research. And a little bit indirectly, partly because of where I was working, I was pulled out of my my bubble of falls prevention and exercise, out of my comfort zone and into areas that were a bit broader. And one of those was the health and wellbeing of carers. And at that stage, I was a bit reluctant. I really wanted to stick to where I was on safe ground. That project was semi-safe. It was looking at exercise options, giving choice of exercise options to older carers. And we looked at general exercise, group exercise programs versus Tai Chi versus yoga. Had some very positive results, and gradually over time, I would say now, and I'm 25 years beyond that point, now carers research would probably make up probably a third of the research that I'm doing. So I still have the passion in falls, but they're not silos. People who have falls has impact on the caregiver and so on. So that's my journey.
Fantastic. Thank you for sharing that, Keith. I think everyone's doing such important work, and I think it also all shows the great diversity of work within the carer space. From so many different perspectives, but with very similar themes as well. Charmaine, thank you for sharing your story earlier and for joining us today. Charmaine, what would be your advice to other carers about getting involved with researchers and projects? And I know you touched on that a little bit before, but do you want to just tell us a little bit more about that?
As you can see, the atmosphere of the video that was made with me and Conrad, Sally and the whole team were so accommodating and reassuring of being able to be vulnerable, because becoming part of research, coming out, it takes a bit of courage, it takes a bit of oomph to not just stay in the hole. The first part is just to walk into the light. It's to meet the people. They care, they genuinely care. And some of them need you as a carer to be able to bring a different perspective of where you're at, what you're doing. Because I remember when I was invited to give the talk, I was sort of bold and brazen to say, could I bring my son with me so that you can see in action what has transpired? And it's this intimacy I used to make jokes in the therapy that I do with kids, is into me you see. But we have truths, we have positive truths, we have negative truths, we have, negativity can completely take over, and being able to move to positivity. And that's why I was so grateful that they allowed us to be together, because that picture and that connection speaks louder than anything. And you can make a difference, no matter how small, how trivial, and just become part of it. And compassion is what draws you to that, because we're all connected. We all need each other and we need to make a difference, because it's horrendous how much is taken in care. I've just lost my father, and I had to go over to South Africa and become a carer. I wasn't, you know, yes, I care for my son, I care for myself, but all of a sudden having to care for somebody that is so frail, and his mind was sharp, but his body wasn't, and keeping a balance, training a night carer and a day carer, and you're not equipped. And if you start banding together and even listening to why all of you got involved in the studies that you do, it's because you've got heart. And it's not just knowledge. Knowledge means nothing. It's actually dangerous. And if people can just realize by becoming part of something, no matter how small, you do make a difference. So that's me.
Fantastic. So I think that's an overwhelmingly positive advertisement for involvement in research. But I think importantly, bringing that lived experience to the research, because I think we can't do it without carers, without the people that we're trying to support, look at better solutions for, and all of that. So I think that really, you know, highlights that importance. And again, thank you, Charmaine, because I think you speak so beautifully. And so to have your input into this has been just lovely. So thank you.
Thank you very much.
That's all right. So just any other, just a reminder, if people want to put any other questions in the chat, happy to sort of look at those. Keith, maybe just from you, can you tell us how have carers been involved in your research process?
Well, within our relatively new research centre, we're aiming to try and involve people with lived experience in the research, right from concept of what we want to be researching through to proposals, through to implementation and dissemination. So that's a general philosophy that we're trying to put into place. And so in our carers research, that would mean trying to involve one or more carers in that planning stage. What is important? Why is it important? In terms of the actual research that we do, carers can be directly involved, as in that third phase that I talked about, where we did the co-design part to come up with what hopefully might be a good model. They can also be indirectly involved. Another project that we've recently got funding for is looking at trying to get people with dementia become more physically active, because they are very physically inactive, and the research is starting to show that if we can, around time of diagnosis of dementia, increase people's physical activity, it's not people with dementia's physical activity, it's not only good from a health and preventing falls, physical health point of view, also from mental health and slowing down the cognitive decline. There's a lot of benefits, but that research needs the caregiver usually to be an active partner in delivering the exercise. So we're really working directly with the person with dementia, but the caregiver is essential. So I'm terming that as indirect involvement in the project. And the third way is through advisory committees on research projects that we run, that actually monitor how we're going, and at every stage of the research provide us with input. And for a carers related project, that would always involve a couple of carers.
Fantastic. So yeah, involved really at kind of every aspect of the research. So that's you know, again, the importance of the lived experience and having that carer voice, and certainly through the range of projects that we do at Carers New South Wales, but particularly with the Carer Knowledge Exchange. We have a carer advisory group, carer reference group, as part of this project, which has been fantastic in, you know, informing our work, our direction, some of the topics that we want to address that we're seeing as important. So it's been invaluable to this project and to progressing our work under the Knowledge Exchange. So Lily, do you want to maybe just share with us where you're taking your research to next?
Sure. And I think the plan for the future research projects and in the caregiver research of the people with dementia have been incorporated in our grant application or both throughout the applications. And I think the effective way and to support the cares is to translate the knowledge into practice, and particularly into the policy changes as well. So our next stage is to use the evidence from our randomized controlled trial and the evidence from systematic review over the world, after the studies we summarized over the world, to inform the policy changes, develop the new services to support the cares, and also to translate the programs we have done into more and more organizations, the dementia care providers, including in the hospital, memory clinics, and geriatric wards, and in the community settings, and the community-aged care organizations, and the transitional care, and so on. And most importantly, we need to translate the knowledge into our culturally and linguistically diverse communities as well, to address the gaps in dementia care support services and the policies between those from the mainstream culture and those from culturally diverse communities. Thanks.
Thank you. And Sally, just a question to you. Can you tell us what your advice would be to give other researchers who work with carers or want to do so from your experience?
Oh, what a great question. I have a lot of advice. But if I'm going to give my top tip, I would say what we want to do is work with and not for family and friends. So that means talking to family and friends, hearing their experiences, being guided by them about what's important to them, and most of all, working with them. You know, I'm constantly challenged by the extent to which we really do co-design our work. And at Every Mind, I think we're doing pretty well, but we're also working to do better. So ultimately, the lived experience of family and friends needs to be central to what we do and how do we do it. That's my advice. Go and make sure that you include the people for whom we are working in the work that you're doing.
Yeah, fantastic. Great message, Sally. Absolutely.
Could I give a comment? I've been listening to all of you beautiful, insightful people. And I'm a play therapist and I work with autistic kids. And one of my kids said, my grandpa is always closed and angry. And he said to me, can I bring him to your center? And I've got an indoor playground. And it was amazing to see how the young boy sort of awakened the old dog. And he was in the ball pit with him, on the jumping castle, playing, Connect Four and all of the games. And I saw an immense improvement with him walking out the doors. So our young generation have got so much to participate and also to learn, because making them part of something takes them away from tech. Because in my center, I don't have tech. The only tech that I do have is an old Xbox 60 where they become the thingy. And it's amazing to play. And it's within this immense playing that I can ask them the most difficult questions. And they answer with ease, because cognitive activity means you're awake and aware and busy. And the body, the mind work together. And that's just from my side. Play with them. Play and teach them.
Fantastic, Charmaine. And yeah, that inclusion and that intergenerational care and involvement in activity, I think, is really important. And we shouldn't make assumptions about things either and about things that we think will work. It's really about observing some of those things and letting them happen like that, which I think is amazing.
Me and Conrad have a code. He comes in and he says, Mum, it's a snap, crackle and pop moment. And the snap is our judgment. The crackle is the bias and the pop is the assumption. And we peel back those things that we've already put into motion by saying, let's just take a step back into ourselves. And I did a university paper on equanimity, learning to be able to sit in the moment with the negative and the positive and be open to yourself, to your own truth, has done wonders within me and Conrad's dynamics. Sorry.
No, thank you. Thanks so much. Look, I think a final question for all of our panel members, for our researchers today. Just again, I'll start with Sally. For those listening today who directly support carers, what would you say is the main takeaway from your research that could inform their practice?
Wow, there were so many takeaways, but I think there's probably the big one for me is about connecting family and friends to others in similar positions. So in our program, we do that through social forums, we do that through face-to-face groups if that's appropriate, or even with online content, such as in the videos that Charmaine stars in and our other family and friends star in our program. Family and friends tell us that hearing the stories of others is amazingly powerful for them. So again, us centering that voice of lived experience in the work we do is crucial. I'd also just say that if you know anyone that you think could benefit from the Minds Together program, please go check out the website. We're really keen for you to do that.
Yeah, fantastic. Thank you, Sally. Keith, main takeaway from your research that could inform the practice of others?
I've just come up with 3 thoughts there. One is to listen to carers about their story and their journey, and from the point of view of this carer clinic, but also more broadly, is to think about and to talk about what are the carers' prioritised needs. We as health professionals often make some assumptions pretty quickly what we think is most valuable, but that may be very left field in terms of where the carer is at that moment and what they really need. And so we need to have a way of getting the carer's needs up front, and also to understand as a health professional the complexity of the carer role, and that a lot of the things that we think might be very valuable, you know, I would be telling everyone to get out there and exercise, and physical activity is so wonderful, but how does that fit in to the constraints of the time, the other demands, the emotional stresses, all of that a carer has to deal with every day? And so sometimes we have to think very laterally around how we make that as a workable option for the carer. So that would be my thoughts on that.
Thanks, Keith. And Lily, your key takeaway from your research that could help others in their practice?
So, yeah, first, the takeaway message is about the self-care for carers. Yeah, I would like our carers to perform self-care, whatever they've got a minute or few seconds. And we know they are very busy. And through Elisa's presentation, we know, and the situation there, we know they couldn't get out. Sometimes they couldn't get out of the houses, but there are different ways, to care for self. Does not need a time. Not some moment will help yourself to improve the health and the well-being. And the second message is to reach out to the family members and the friends and the community to get help. Never be isolated at home. And you'll find, many people share the same experience, and you'll find the support around you. And and also for the dementia, we know it's associated with the stigma, and we need to attack the stigma in our society and always get the diagnosis for the loved ones if you identified any signs of the dementia. And there are so many benefits once you've received the diagnosis. You get more support from the community and from the society. And by work as a community, we can attack the stigma and we'll build more support for the carers. Thank you.
Thanks so much, Lily. Charmaine, I'll give you the final word in terms of the main takeaway for researchers that could help inform their practice.
Everybody has got the idea that meeting somebody where they're at is very, very important, because my journey went from caring for one kid and losing sight that somebody quite close to him was also going through a big problem. And then you've got to have this massive, you've got to deal with grief and loss. And grief is not a kind dorm matron. Then, you fall into these negative, scared, frantic problems. Your anxiety gets the better of you, and caring becomes a prison. It becomes a stronghold that it just pulls you down and down and down. So as a carer, I've got a very positive attitude at the moment, but it has been a journey. And you need to be able to get out of the constraints. You need to get out of your mind and into your heart. And you need to get to your truth. And if you guys can help people realize they make a difference, that the smallest bit that they do is so important. And me and Conrad got into a bit of a rut because all we spoke about was negative and problems. And we sat down together and he said, Mum, we need to bring a bit of positivity into this. And it's not a habit, it's something beautiful. So we always check in on each other. And Lily, you saying that the people that work with dementia need to reach out, the carers, it's so important. It's like stagnant water gets thick. The river needs to flow. And that's the part that I've taken on board. Just being able to talk without just bursting into tears is a big thing for me already. Because in the beginning, after the loss of Shani, it's as if I lost sight. If my two kids that stayed over got into a car, I was in a frantic fit because I was scared, and anxiety mucks your mind up, and not knowing mucks your mind up. So the more information, the more outreaches, the more lived experience, drawing people out of the shadows and saying, you have a voice. It's what you're going through is horrendous, but you've got insight and you've got wisdom. You do things that are working, and being able to share that is what compassion is all about. We all are together. We all work. We can become one mind. We can change the course of a river. We can take a stagnant pool and make it flow. So that's my take for you guys.
Thank you so much, Charmaine. Thank you to everybody. I think my little message from that was the river needs to flow, which I think is a really lovely way of putting it. So thank you for sharing. So look, I haven't got any other questions at the moment, so we will finish here. A very big thank you to all of our speakers today, Sally, Charmaine, Lily and Keith, and also Eliza that joined Lily, who had to leave. Thank you so much for sharing all of your information, research, and fantastic work that you're doing in the carer space. And I'm sure that everybody that's listened today and participated has taken away some really fantastic key messages and things that will influence their practice and work. So thank you so much for that focus on carer health and wellbeing. I'd like to invite everybody to continue to engage with the remaining sessions today. We've got the spotlight session in a few moments, and then we've got the sessions tomorrow and Thursday. But also a big thank you to everybody at IPPG and Carers New South Wales, the Carer Knowledge Exchange team, particularly Joanne, Tian, Lucy and Sarah for all their work in pulling this together. But there's also a whole team of other people in the background making sure that the tech and everything works well, and they will continue to do that over the next few sessions this week. So again, thank you for everyone. There's a feedback sheet on your form on your screen now that you can also respond to. So thank you very much. Please stay on for the Spotlight series, and I hope you enjoy the rest of the week, and thank you to everybody.